In the transplant-eligible newly diagnosed myeloma patients, the induction regimes slightly evolved over time. Definitely, every newly diagnosed myeloma patient transplant-eligible has to receive 3 drug-based combination, and the proteasome inhibitor as well as the IMiD and dexamethasone should take part of this induction regime. VRD is becoming one of the standard of cares for this population, as well as VTD, bortezomib, thalidomide, and dexamethasone. The main differences between VRD and VTD is basically based on the switching of thalidomide by lenalidomide makes VRD a combination a bit more effective than bortezomib, thalidomide, and dexamethasone, but most importantly, the safety profile is much more better because lenalidomide does not induce the peripheral neuropathy. Under this platform, basically based on VRD and VTD, I think the next step is to add monoclonal antibodies. And VTD plus daratumumab has been evaluated in the Cassiopeia study, in a phase 3 randomized study in which the addition of dara to VTD resulted into a significant benefit in terms of stringent complete response rates after consolidation, that it was the primary endpoint. But from my point of view, it is also relevant to say how the addition of daratumumab increased the proportion of patients achieving minimal residual disease negative, and this translated into a significant benefit in terms of progression-free survival. Honestly and personally, I consider that we are moving towards the use of VTD plus dara today, but the next new standard of care would be VRD plus daratumumab, and this combination is being evaluated right now in the Perseus study, and results are pending because although the trial already recruited all patients, the primary endpoint has not been reached yet. It's true also that daratumumab is not going to be the only anti-CD38 monoclonal antibody added to this standard of cares, and isatuximab is another anti-CD38 monoclonal antibody under investigation, also in combination with the 3 drug-based combination in newly diagnosed myeloma patients. And for example, carfilzomib, lenalidomide, and dexamethasone plus isatuximab is being evaluated in high-risk newly diagnosed myeloma patients. So basically, I think that the next step would be to incorporate the anti-CD38 monoclonal antibodies to this standard of cares right now for this population, VTD or VRD. And one question is, what about KRD? And carfilzomib, lenalidomide, and dexamethasone has just been compared with bortezomib, lenalidomide, and dexamethasone in the endurance study conducted by the ECOG group in the US, and in newly diagnosed myeloma patients at standard risk, VRD showed to be comparable to carfilzomib, lenalidomide, and dexamethasone. So we will see what happens with patients with high-risk cytogenetic abnormalities, and maybe there is a role for carfilzomib in this specific subgroup of patients.